Okay, Henrietta, we're good to go.
Great, thanks, Jeremy. Welcome everybody out there. Just to let you know that Jeremy is recording this, so this is going to be a public recording that you'll also receive after this free webinar tonight too. So welcome tonight to this 1.5 to 2 hour free introductory webinar to the End of Life Nurse Coaching Program, which is to be held at the Open Centre. It's a collaboration between the Art of Dying Institute and the International Nurse Coach Association. And Joanne Turnier is here tonight to give her presentation. The other faculty members who will be conducting this course are Barbara Dossi, Susan Luck, Jan Booth, who we heard from a couple of weeks ago, and Deborah McElligott. So this training will start on November the 9th and it will go through to the spring. And I'm sure Joanne will outline how that's going to work for you. But please, as Jeremy said, feel free to ask any questions at all about the course, how it's going to be run. And I really do encourage you to join in after Joanne's presentation to really talk to her and just share any questions from the heart and share your experience, you know, where you are in your nursing career, where you hope to go, just anything you'd like to share. This is a, you know, shared event. It's not really a solo presentation. We don't like to see it like that. So it's wonderful to have you all with us. Joanne, I'm going to give you a quick introduction and your work, and then I'll pass over to you. So Joanne is a board-certified adult clinical nurse specialist and integrative health and wellness nurse coach. Her nursing career spans over 25 years with experience in neonatal intensive care, neuroscience, palliative, and end-of-life nursing. Joanne has primarily practiced in acute care, community health, and corporate healthcare settings with a focus on patient-centered care, program development, health literacy, cultural diversity, and end of life. Currently, Joanne works as an integrative health and wellness nurse coach in private practice in Northport, New York, focusing on health promotion and bereavement support. She also serves as adjunct faculty at St. Joseph's College, located on Long Island, New York, and associate faculty for the International Nurse Coach Association. Joanne has maintained certification in thanatology through the Association of Death Education and Counseling since 2003. She currently serves as an advisory board member of the American Nurses Association's Palliative and Hospice Nursing Professional Issues panel. Joanne has presented on a number of topics nationally and internationally. Joanne, thank you so much. We're honored to have you tonight, and we're really looking forward to what you have to share with us. Thank you.
Thank you so much, Henrietta. It's a pleasure to be here. I'm so delighted that the Open Center and International Nurse Coach Association has come together to offer an end-of-life nurse coaching program. You know, I'm just so excited because as we view it, and the folks in International Nurse Coach Association and my dear colleague, Jan Booth, who has been working in hospice and palliative care for many years, we believe that hospice and, well, really palliative care is something that should be introduced a lot earlier in the trajectory of illness. And the way nurse coaching can help with that is by helping nurses to use the coaching model as they companion clients through their trajectory of illness. So for tonight, I'm going to, you know, go through the PowerPoint presentation that we have, and I'm hoping that this would cover some of your questions and you're wondering, and help us to explore a bit about nurse coaching and how it fits into end-of-life care. And also then I'd be happy to take any questions. I'm just wondering how many of you work in palliative care or hospice already, and you know, what is it in particular that where you would I want you to think about where you would like to use the nurse coaching process. I'm going to go through the PowerPoint first, and then of course Jeremy will field questions at the end. So certainly, I got interested in end-of-life care as a neonatal ICU nurse, where I felt very helpless as a nurse. I was trying to save the lives of neonates, and many of them died, and I just couldn't understand it. And so that sparked my interest in end-of-life care, and how would I, in my helplessness, make a difference for parents who lost babies. And, you know, that started my inquisitiveness and my exploration into end-of-life care, joining with other nurses in my unit to create a perinatal bereavement program and aftercare program for neonates who passed. So when we look at, you know, a broader look at death and dying, as I went through my nursing career, the patients that I've companioned through end-of-life care, you know, no one has ever said to me, gee, I wish I had my diamond ring when they were on their deathbed, or I wish I had my convertible with me. And, you know, but most of them, you know, had different regrets. I wish I hadn't worked so hard. I wish I had the courage to express my feelings throughout my life. I wish I had the courage to live life true to myself and not, you know, live a life that others expected of me. I wish I had stayed in touch with my friends. I wish that I had let myself feel happiness. So, you know, as a end-of-life nurse, we try to, you know, talk to patients and find out what it is that they need, you know, during their disease trajectory and at the end of life. And they share so much with us. So that's important to realize. So the starting point, you know, we live in a death-phobic society. You know, at post-World War II, you know, we got antibiotics and all the technologies came, and here we thought we could fix everything. And, you know, death and waking and rituals started to be taken out of the home and into funeral homes. People were, you know, instead of being home and being ill, they were brought to hospitals so that they could receive the technologies. And hence, you know, Frankenstein, you know, the story came out and, you know, really gave us a different way to look at death. So when we look at death, I don't think death is a medical event or a failure or a problem to be solved. It's just something that is going to happen to each and every one of us. It's a natural part of the life cycle. And in my experience, it has, many families have shared meaning, what patients and families have shared, what it meant for them to be living with a terminal illness, how it transformed their life. There are so many books out there that share, you know, how if I never had cancer, I wouldn't have A, B, C, or D. I'm sure we've read all those Final Gifts and many, many other books. Many people come into the last part of their lives feeling unprepared and afraid. We don't know what to expect. I remember a priest that I knew who was coming to the end of his life, and he was very frightened, and he was almost had spiritual distress because he felt so afraid to die, and he felt so guilty that he was afraid to die because he was a priest. And he said, I should have faith and I should know, you know, where I'm going. What is this? I feel unprepared. I feel afraid. So it's important to be able to create a safe environment that can explore those feelings, you know, that patients and families are having. There's also, I believe, a greater cultural awareness that we need to navigate more consciously and take a compassionate approach to end-of-life care. You know, I believe, you know, we don't start or initiate palliative care early enough in the disease trajectory. And I believe that palliative care and curative care should travel simultaneously and should be seamless. But I don't think our culture is there at this point. So what's new here? Why is end-of-life integrative nurse coaching different? Well, I believe it's a new innovative response to the crisis of how we die in this country. You can read all the hospice literature that, we get to hospice really 48 hours before we die. Many of us die in pain. Many of us have regrets, the 5 regrets that I just shared with you previously. But I also think that it's time now with the Affordable Care Act from a health system perspective. There should be a collaboration between integrative nurse coaching and some forward thinking of organizations. It's a new model. We keep doing the same thing and it's just not working. But now I believe it's time to change course. I believe integrative nurse coaching is an opportunity for nurses to take a different leadership in the care of people with advanced illness and end-of-life care. I believe that, we meet the client where they are. From the moment they're diagnosed, that conversation is going to be very, very different than the conversation about end-of-life care. And as they are living longer with chronic illness, there'll be opportunities along that journey to be present and really help the client navigate through the disease process and live well with the disease, as my colleague Jan always brings up, living well with illness. I don't think that being healthy is the absence of disease. I believe we can live with illness and be as healthy and live as well as we optimize our wellness, even though we're living with a chronic disease. This program also will create a new role on leading and lead and have a leading edge in healthcare. I don't know of any. I've heard of health coaches being, nurse navigators, but the nursing profession lends itself to coaching because we are natural coaches. It is just who we are. We bring not only the coaching competencies, which we learn throughout the program, but we bring our years of experience as registered nurses. And I think that's what separates us from others and other health coaches. And we also have a theory of integrative nurse coaching that Barbara Dossi developed in 2010. And one of the components, the first component, as a matter of fact, which you'll be learning throughout this course, is self-development. This is a key component. The self-development incorporates self-care for nurses. It incorporates self-reflection, self-evaluation, and self-exploration. It not only tells us that self-care is necessary, it provides the how-to components that we practice over time, and we just become committed to our own self-care because we really know that in all this consciousness that we have here, that, we are our patients. We are one another. What we do as a human being reflects or has a ripple effect to everything and everyone we come in contact with. So it's from this premise that we're committed to our self-care. And from the American Nurses Association and from a leadership perspective, the ANA position statement on nurses' roles and responsibility in providing and supporting end-of-life care, the ANA says decision-making for end-of-life care of patients should occur over years rather than just minutes or days before the patient's death. And all too often, we as nurses see this happening, it's just heartbreaking, and it causes a lot of issues for us in our own profession, like compassion fatigue and burnout and moral distress, when we're constantly exposed to what I believe is the suffering that doesn't need to happen. If we, go upstream a bit and really start to talk about preferences and choices and how folks want to live throughout their illness trajectory. Also, nurses can be a resource and support for patients and families at the end of life. And in decision-making in the decision-making that precedes it. I love advanced directives, and I think everyone should have one, but there are so many gray areas. The reason why there's so many pitfalls in advanced care planning is because we're trying to predict what will happen at the end of life. And that's a very gray area. It's all well and good while we're healthy and we're saying, yes, I want this, no, I don't want that. But all of those situations that occur at the time, in real time, as we have to make those decisions, can happen just when we're healthy. Maybe we need to start to think about it and what the options are, but those discussions have to occur throughout the trajectory of illness, because things may change. Thought processes may change. The way we are living with an illness and our resiliency as we live with an illness may change. So that's very important to realize. Nurses are often ideally positioned to contribute to conversations about end-of-life care and decisions, including maintaining a focus on patients' preferences and to establish mechanisms to respect the patient's autonomy. Well, I am a firm believer in autonomy for patients and self-determination. But in my practice, I found throughout the years that folks didn't have the ability to be autonomous because they didn't know about their illness. They didn't know what was happening to them. There were gaps in the knowledge that they had about their illness trajectory. So I think it's very important to speak to patients throughout from a health literacy and cultural awareness perspective to empower them as they walk through, and their readiness to hear about their illness is fluctuates, and I think what the nurse coach model does is it kind of teaches nurses to listen for that readiness and to deeply listen to what the patient is saying, and then ask questions that will help the patient to find their own answers deep within their own wisdom within themselves. So it's a very beautiful model. So here we have these perspectives. We have nurse leadership, we have the coaching perspective, and end-of-life care. And these all intertwine with one another. So the end-of-life coaching program will be a 6-month integrative nurse coaching certificate program. And I want to tell you a little bit about how this began. Barbara Dossi, who's been a holistic nurse since the 70s, she's very well written in the arena of holistic nursing, was attending conferences and realized that folks were calling themselves health and wellness coaches. And she was at a program and found that after the program asked one of the coaches, so where have you studied? And the coach said, I haven't studied. She goes, I was a Weight Watcher leader. And, I just started my practice. And Dr. Dossi said, this hit me like a ton of bricks, she said, because who better to coach patients than registered nurses? Who better than, nurses who have all of that experience? We're there with a patient. Often when a patient's born, the first person they see is a nurse. And when a patient dies, often the last person they see is a nurse. So we're there throughout their whole life continuum. So Barbie created, spoke with the ANA and set up, established a committee and really created a theory of integrative nurse coaching. And created the program along with Susan Luck. And this is a 6-month program that would allow folks who take the program to be eligible to sit for the integrative nurse coach boards, but also the holistic nursing boards, because it's a 120 continuing education program. So we're going to be starting the end-of-life program in November. But there will be 3 months in between where every student will have a supervisor and they will have to go through independent study, like, see clients and write up 3 transcripts and present a case study on, we'll have monthly calls, have an awareness and a peer coach throughout those months and really work on their own self-development. And then we come back in April and we have module 2 where we're learning more about nutrition and learning more about end-of-life care and the applications and working in triads and dyads around end-of-life care. So we're also so delighted to be collaborating with the Open Center and the Art of Dying Institute. What a perfect marriage, if you will, a collaboration. So the program will be held there. So who can be a nurse coach? Who are we targeting? Anyone with a minimum of a bachelor's degree can sit for the certification, but anyone can implement nurse coaching skills. So the target group here is all nurses who want to make a positive difference in the lives of people with chronic illness, advanced illness, and at the end of life. And also want to change the way they feel, want to change their own habits, want to feel better about self, want to feel better about going to work every day. I've been a nurse for a very long time, and I've seen the transitions throughout, hospital systems and in healthcare. And it can be very devastating for nurses because I feel that sometimes the environment doesn't lend itself to us practicing the art of nursing. And we're there with the science, we're there with the electronic medical record, which is very important, but creates a lot of obstacles for us in regard to the art of our nursing and the way we express our sense of caring and the time that we have to express our sense of caring. So the coaching really helps with, helping us to calm down and to dig deep and find out, what makes us tick and what can help us to navigate through stressful arenas. So nurse coaching, and especially end-of-life care, may be particularly relevant in critical care, in chronic disease management, of course, oncology, hospice, palliative care, long-term care, home care, parish outreach, community outreach, and also private practice. I have a private practice in Northport. I teach, throughout the country with the Integrative Nurse Coach Association, so my practice is small, but on the times that I don't teach, I can, expand if I want. So it gives me that flexibility. So the program format that you'll be experiencing is a 60 hours of experiential learning. The two, Module 1 and Module 2 are separated by, they're 4.5 days on-site modules. And then I said you do that independent study. And then you can see on the screen that we'll meet Wednesday, Thursday, Friday, Saturday, and half a day Sunday. And you'll see all the contact hours that you receive for each day. So it's very important to attend the full program. It's the 60 hours in between of the self-paced supervision. That happens between the modules. That's self-paced, but along with your supervisor, you'll come up with dates when things are due so that you move along at a nice pace. And then your supervisor is there to answer any questions. It's a phone call away. And some of us are even thinking about doing this wonderful Zoom in, which is so fabulous. So the tuition at the Open Center is $4,995, but you get 120 CE credits, which makes you eligible to take the holistic nursing certification as well as the nurse coaching. Also, I have to tell everyone who's on that we do have scholarships that we're willing to give, 500 scholarships to help with the cost. So I'm not sure about how many people are on this call, but we do have some money to do that. The benefits of the end-of-life nurse coaching program. It's a comprehensive program. You become board certified as an NCBC. If you take the holistic nursing certification, then you're eligible to be called a health and wellness nurse coach board certified. So there's those two benefits of it. Also for ADEC, the Association for Death Education and Counseling, which is a fabulous organization. Back when I was doing the neonatal and perinatal bereavement programs, and then I had branched out into a family support service for a tertiary facility in Nassau County, where we cared for families who were experiencing traumatic death, and that branched out into becoming a consult service for anyone who was dealing with any end of life or sudden onset of illness throughout the hospital. And I have to tell you, back in those days, there was nothing out there like this. So I found refuge with ADEC, and I became certified. ADEC requires 60 hours for you to be able to sit for their exam. And you get a certification in thanatology, which is CT. Those conferences that they offer all the latest research on end-of-life care, on sibling grief. Ken Doker and Terry Martin talk about instrumental and intuitive grieving. Amazing work. So there's a great benefit to taking that exam and having exposure to the Association for Death Education and Counseling. I think also what this program did for me, I had left corporate healthcare. I was the director of patient education and health literacy for a major tertiary or quaternary institution here in New York, and I just had enough. And I went to my first coaching class, and I was in pretty bad shape, I have to say. I went to one day where all of a sudden I felt like I was starting to feel my soul within my body again, and I was with like-minded nurses who I connected with. By the end of that one-day class, they were not strangers to me anymore. They were just loving beings who we were all on a journey of self-development and renewal. And when I attended Module 1 and began to meditate every day and began to eat mindfully and began to incorporate all of the healing modalities that I was exposed to, and had the support of community through the International Nurse Coach Association and through my own cohort, really amazing. And now, almost 3 years later, here I am, meditating every day, and changed my whole nursing career. So there's something to be said to really, we've been taught as caregivers that we're always giving, and we love giving. That's why most of us became a nurse. But it's very important to renew our soul and to renew our spirit, so that when we go into those hospital rooms or into that doctor's office or into that parish family home, or we have something to give, we can spread a little sunshine, and really be totally present, which I think is healing in and of itself. So another thing I love about International Nurse Coaching is that we're becoming part of a global network. We presented all over the world. As a matter of fact, I got home from Washington State last night, and we taught a cohort 15 actually, at Harmony Hill in Union, Washington, right by the Hood Canal, which was amazing. And there were some nurses there from New Zealand. So we've also had nurses from Brazil and Iceland and all over the world. Wales and Great Britain. So this is catching on, and we, at a moment's notice, we can hit LinkedIn or do a free conference call and gather together and have that support. So what is a nurse coach? Okay, a nurse coach is a registered nurse or an advanced practice registered nurse who integrates coaching competencies into any setting or specialty area of practice to facilitate a process of change or development that helps individuals or groups realize their potential. So the biggest issue with a nurse coach, when you're starting to become a nurse coach and you're practicing, we always, nurses have algorithms. We love algorithms. We love to tell people what to do. We love to hand out, patient education, and and we kind of get lost in that. But the wonderful thing about nurse coaching is that we do a lot of listening, and we wait for the invitation to be invited to ask a question, which is so beautiful. And we learn to trust the process, and we learn that it's okay not to know. And I don't know about you guys, but for me as a nurse, I had to know everything. When I didn't know everything, I was a little upset. So it's a new way of being, and it works beautifully when you see the client's story unfold and you see these aha moments that come out of the client just by asking, beautiful questions, using some motivational interviewing, using some appreciative inquiry. It's truly, truly an amazing process. So I have the solution to all of your health problems. All you have to do is change everything about the way you live. And you know what? In this day and age, maybe that's what people feel like. You have to change your diet. You have to change, your exercise. You have to change your stress levels. You have to change. And you know what? There's so much more to change, which we'll learn through the coaching model, than just having to tell someone they need to change, and even to get sustainable change. So how is coaching different from teaching, counseling, advising, advocating? That's those are buzzwords for nursing and for folks who, therapists. Coaching isn't therapy. It's, the client takes the lead. The mode of support is exploration, and the coaches, helps the client to explore and, approaches the client with curiosity. It's collaborative. It's not directive. It's time limited. And it's goal oriented. The clients come up with their goals. Even though, our nurse mind, and this is the issue nurses have with coaching when they first start, is the chatter is going on in the brain while you're listening and saying, oh my God, if they would only stop smoking, oh my gosh, if they would only stop, eating, a poor diet. And, I really want to give them some information about this. Yeah, there is a place for teaching and coaching too, but mostly the client comes up with their goals and their confidence levels and, how ready they are to make the changes. And it builds upon the client's strengths and helps them to focus on their strengths. So I don't want to call it empowerment, because I believe we're all empowered already, but coaching helps the client tap into their own power. And when that happens, it's truly a miraculous thing. So it shifts from compliance or adherence to cooperation and collaboration. So what are some of the coaching skills? And you're going to see how this aligns with nursing. Active listening. And I really mean active listening, stopping the chatter in your brain, sitting for a moment, and being present in that moment and listening to what the client is saying and asking open-ended questions. Now, I don't know about you, but this looks very familiar in Nursing 101 many moons ago when but are we permitted to do this? The coaching model allows this to happen. Motivational interviewing, change talk. Okay, so say if an example of motivational interviewing would be, say if a client said, I really know I should quit smoking, but I just don't want to now. I just can't. I love to smoke, but maybe previously they mentioned how they wanted to be around to, in years to come, to see their grandchildren grow older, or to see their daughter get married, or to do something that they were looking forward to. In motivational interviewing, one of the techniques is to create discrepancy. So, we listen for that, and then we create discrepancy and to give the client some food for thought. So there are many books on motivational interviewing, and you'll learn about how to optimally use motivational interviewing. Appreciative inquiry is another wonderful tool to use. What's working? Going back to imagining. Can you imagine, what your life would be like if you didn't smoke? Or could you imagine what your life would be like if you, weren't huffing and puffing when you exercise? So, and also it's tapping into the client's resiliency. And really helping them to know that they have hardiness, they have resiliency. Building on the client's strengths is positive psychology. We use a lot of positive psychology because part of making change, a sustainable change, is to help folks understand their strengths. Just by what they're saying to you, they may not even be in the forefront of their mind to even know that that's a strength until you bring it out through your dialogues and through your exploration. It helps them develop. They, develop as a human being. Nurse coaching has helped me develop myself and continues to be an ongoing process of work and how to develop myself to my full potential, which is an everyday task and a wonderful task because now I have the tools to do it. Mindfulness studies, we use a lot of awareness practice and imagery, and when folks get stuck or when we get stuck, we have, tap into a multitude of different imageries and awareness practices that have helped my clients to, look at something from a different perspective. And really, it's, coaching can be instilled throughout the life spectrum. I have had folks that I've coached for 6 months, and then they decide they want to stop for a little while, but they come and check in now and again, whenever they need to, and then we have a few sessions. So it's really amazing that that model is always there and can be picked up along the whole life continuum. And it can happen, coaching can be integrated even in, if you're doing genetic testing for, parents, or if you're, for new moms and dads, and, for kids who are living with a childhood illness and helping their parents and helping teachers and so on and so forth. And self-development and care, self-care is key, because while you're being the coach, it is so important for you as a nurse or me as a nurse to develop and care for myself as I'm, practicing what I preach and having the tools that I need to do that. So, what can you do when you're a nurse coach? I mean, you can do so many things. I mean, in end-of-life care, health and wellness, stress management. You can start your own coaching practice. You can use these coaching skills to expand your current work. I mean, I know a nurse who worked in integrative cardiology in the hospital, and not integrative, interventional cardiology in the hospital setting. And she began to get the patient list the night before and came in early and did meditation with some of the clients who were open to it before their procedure, and then saw them afterwards. I've done this with my clients in the neuroscience world as well, and it really works. So you don't need permission to do these things. You can just integrate them into your practice. So I think that's the really neat thing about coaching. It can be integrated throughout the trajectory of illness. So you don't have to wait until someone is 48 hours away from dying. You certainly can integrate it throughout and help folks to live fully, while they're living with an illness. It also, the coaching lens brings nurse coaching, this work into hospice and palliative care. And our hospice and palliative care colleagues are proficient in these areas. But I really think the self-care component of coaching and really tuning into all of those skill sets really just add an extra value to the palliative care and hospice world. I think serving as an internal coach within the healthcare system, we're now trying to integrate nurse coaching and using our theory of integrative nurse coaching as a professional practice model. In some health systems throughout the country are very interested in doing this. So, that's another place you can bring it. Also, it aligns beautifully with Magnet, the forces of Magnet. So our one-day course we're teaching here on Long Island on September 29th, just a little plug, we're aligning that course with the forces of magnets. So that would meet a standard that magnet hospitals have to have. Also, focusing coaching on professional and personal caregivers. My dear colleague, Dr. McElligott, and I have done a number of care for the caregiver and programs for nurses to really give them some respite and really help them to search for meaning in their caregiving. So I think the coaching model is just a natural, fit for that. And I think also coaching can contribute to your end of life, the skills at end of life, and also have a place in advocacy and policy work. One example of this is I sit on the advisory board for hospice and palliative care for the ANA, and we have a wealth of knowledge and for the folks who serve on that committee, and I have shared a lot of aspects of the coaching model on that, and I would love to see the coaching model be part of changing health policy in this country as we move forward with the Affordable Care Act. So there is a lot of possibility here, nurse coaching. So why are we focusing on end-of-life care? If any of you have read the IOM's report, Dying in America, Improving the Quality and End of Life and Honoring Individual Preferences Near End of Life, we as nurses, we witness advanced illness and dying. We need to start thinking about dying in a new way. The baby boomers are living longer with chronic illness, and all the literature still shows that there's a shortage of end of life skills among nurses. We're not learning it in any depth in nursing schools. We can take LNEC, which is the End of Life Nursing Education Consortium, but does that truly help us to be present throughout a trajectory of illness, or does it give us just some tools? It's a generalization. And also I think nurses are the #1 most trusted profession. I mean, that came out years ago in 9/11, firefighters and nurses are the most trusted profession. And, patients say things to nurses before they even say them to their physicians. So I think this is kind of a no-brainer. And also the self-development skills, because when you're working in end-of-life care and, you're constantly exposed to another suffering, many of us don't realize the changes that are happening within us as caregivers, as professional caregivers. We're always on. We always think that, we have to put our feelings aside. And before we know it, we're numb. We're, it's trickling into our personal life. There are many, many consequences of this work. And I want to bring something else to your attention. When firefighters and police officers have a difficult case, and they're usually first responders, even EMS folks, after they have a difficult case or something that was a traumatic case, they are allowed to take off for a few days, and they have to go to the psychologist or some health provider that the fire station provides to process or search for meaning in their caregiving. I believe nurses are first responders too, but only we don't get to leave the client after the trauma. We get to stay with the client through the whole deal. So what is that doing to us? Why are we, not thinking about self-care? It's not even on our radar. We just keep going and going and going. It's like, the treadmill, we're on a treadmill and we're running steadily and we're getting tired, okay? But the treadmill is turned up and we still say, I'm getting tired. Well, I'm really sorry you're tired, but I have to turn it up some more. How we're responsible for ourselves, or we should be responsible for ourselves, and stop thinking or having the notion that caring for oneself is selfish. when really it's honoring who we are as human beings. So that's the skill for this, the self-development. So again, end of life, innovation and reform. The first wave's hospice, and you know, Florence Wald, she was out there. The nurses became the bridge between patients and doctors and MDs. The second wave was palliative care, and everyone, you know, what we found on the advisory board was that, you know, we make up the definition of palliative care as we go along. Certainly the Center for the Advancement of Palliative Care in New York City gets it. They have a wonderful definition of palliative care, which I think we all should adopt, and we'll talk more about that during the course. But again, you know, we just make it up as we go along. You know, there are so many misconceptions about palliative care, which we'd love to clear up. And, you know, palliative care, I guess I said before, as I say again, should travel with care. It's not separate from care. It doesn't mean the patient is dying. It means that they need maybe more symptom management, or perhaps the family needs more support, or perhaps they need more pain management as they're living with their disease. The third wave is this innovation. That's happening now. Conversations, engaging in conversations, caring at the bedside and after death care. So very important. So there are also changes about where we die. I spoke a little bit about this on the intro. You know, where we die shifted dramatically. 75% of Americans died at home in the 1920s. You know, it was normal to die at home. The woman of the house took care of the patient, person that was dying, and the family gathered together, you know. They waked. I remember my grandmother talking about waking her, you know, mother and father in the parlor, hence funeral parlor, you know, and how that was. The person just stayed in the house. So in 2014, 63% of Americans died in hospitals. So how we died is changing. You know, before 1974, you know, sudden death. I mean, we had, you know, trauma and other, you know, diseases, cardiac arrest. We didn't have all of the modalities and the ways that we can, you know, resuscitate and so on and so forth early on, or didn't do a very good job of it anyway. And after this, now we're dying slow. You know, we're dying with chronic illness, a piece at a time. 7 of 10 Americans die from chronic illness. The average life expectancy doubled past 100 years old. And, you know, we're not, you know, all together in our little compounds as families. We live all over the world, all over the country. So it's the decentralization of the family, really. So, you know, those are the significant things that have changed the way we die. And the realities are that 80% of Americans want to die at home, yet only 21% die at home. 20 to 30% of Americans have advanced directives. Only 25% of physicians knew their patients had advanced directives on file. And the median length of hospice services is 17 days. Why aren't we getting them there sooner? Because, oh, we don't want to give up. You know, actually, folks who get palliative care earlier on and go to hospice earlier actually live longer. Patients who talk with their families and healthcare providers about their preferences of end-of-life care, the literature supports that they have less fear and anxiety. They're more able to influence and direct their medical care. The healthcare team had a better understanding of their wishes, and they had greater understanding of comfort level before they moved into the end stages. So when do we start dying? When? Is it 24 hours before we die? Is it, 48 hours? Is it 17 days? Well, I would like to propose that we start dying from the moment we come out of the womb. Only we don't notice it because we're too busy being alive. So, and I think what's been very eye-opening for me is because being exposed to death and dying for so many years and witnessing, bearing witness to my patients' stories and their family stories made me think about my own mortality and how I could best live my best life, because it's finite. And once we realize that, we would start living, or I, for me at least, start living to my fullest. So when do we start dying? Is it when we're living with serious illness, dying from serious illness, transitioning from living to dying trajectories? And when do we start talking about it? These are questions that we kind of need to ponder. So what does dying well look like? Dying well is an unthinkable thought in our culture, and we don't believe in dying. We're just going to keep going on forever. And it takes about as much courage as wisdom as you can to manage to do it. Dying well is a life's work. And this was taken from Dying Wise in 2015, Manifesto for Sanctity and Soul by Jenkinson. He says it so eloquently. A new model for end-of-life care. And I think it's time for us to think about all of this differently. Okay, living with the end in mind. Just like I said, if I know there's an end in mind and I know that my time is finite, what would I do with that time? Would I be doing the same thing I'm doing now? It's like saying, I'm getting on in years and, maybe I have 25, 30 years. What would I do? How would I, make the best of the 30 years I have left on this earth? So decision making should be based on what matters most to me, what matters most to you, what matters most to our clients, to that person and their family. And we need to begin to normalize those conversations, especially if someone's living with chronic illness or advanced illness. And I think that, like I said, health isn't the absence of disease. It's creating a state of well-being while we're living and walking through that illness trajectory. And the way we do this is through this new model of end-of-life care. So well-being is a general term, for the condition of an individual or group in their social, economic, psychosocial, spiritual, or medical state, which is based on the idea that the way each person thinks and feels about how his or her life is meaningful and important. So how do we keep this conversation going? And even on one's deathbed, how is their life still meaningful and important? As they walk through their illness. So, living fully, dying well. There's a few ways we can do it, and I'm sure you as nurses have seen it. There's one story, and for some folks, this works. Okay. It's a very familiar story, and but I think the most important thing is when we see patients die on mechanical ventilation with feeding tubes in their active dying process. To me, it's a failure in the way healthcare is not, or clinicians, or we have not addressed perhaps some of the issues, or perhaps this patient thought he was being autonomous but didn't have all the information because we're afraid to talk about it. So that's very important to understand. This is another story where, death is just part of life. And, the way we're born is the way we die, hopefully with loving arms around us, and hopefully someone greeting us wherever you believe the other side is, and just looking at it as part of life. So a goal without a plan is just a wish. And I can't tell you how this rings so true. So, we might have planned better. We might have had the goal. We might have said, "Oh, I don't want to die in mechanical ventilation," or perhaps the person we chose is unable to take us off or decided to put us on for whatever reason. So it's very important to plan. It's very important to keep those conversations open because, like I said, there are gray areas throughout the trajectory of illness. There are the readiness to hear different aspects of illness present themselves throughout different components of the trajectory, throughout that journey. So it's really important to keep those conversations going. Through the coaching relationship of trust and mutual respect, the integrative nurse coach and the client are engaged in a manner that allows for a shift in consciousness, an exploration of life's journey, health, well-being, goals, and transformation. And this comes from Barbara Dossi and Susan Luck in the looking at nurse coaching through a nursing lens. And this is so true. I mean, it's a shift in the way we think about our awareness, about the way we explore our life's journey and our goals, which change throughout the trajectory of our illness. Again, the self-care and the self-development. I mean, how many nurses are leaving the profession, and new nurses, mind you, new young nurses who go through orientation and go through their preceptorship, and they leave because they didn't expect they didn't expect what they were seeing. So where does self-care fit into all of this? Where do our own end-of-life wishes and conversations fit into all of this? Are we afraid to be vulnerable to this? Where are our vulnerabilities that prevent us from kind of talking about it? And what are the next steps, for us in our reflections and our awareness practices and the way we personally get coached by our peers? I mean, this is all helps us to learn more about ourselves and our own vulnerabilities and and it helps us to search for meaning in our caregiving, which is so very important. Viktor Frankl, said, and he was in the Holocaust, he wrote Man's Search for Meaning many years ago when he was a psychiatrist who was in the concentration camps. And, he said that we have to be able to turn our predicament, which could be a tragedy, into a triumph. So how do we reframe the stories that we see on a daily basis, the bearing witness to the suffering we see on a daily basis? How do we reframe that? And how does that help us to feel more alive and more resilient? It's through our own search, I believe. And that's what the coaching brings to the self-development component. As living human beings, the most rewarding purpose of our lives is to awaken to our deepest reality, to unfold our most powerful energies of love and compassion. The study and the preparation for death may be the greatest opportunity towards learning to live a fuller life. And once we know some good thing is coming to an end, we want more of it. So the way I feel is that the sooner I realize that the time I have on this earth is finite, the sooner I'm going to live my best life. So important. So what are your next steps? Your next steps are to register for the program, and here I'm sure Jeremy has put this up for you. If you'd like to know more information about integrative nurse coaching, please go to our website, inursecoach.com, and there are some videos up there. There are information about programs throughout the country. Also, there's the Open Center website you can go on to, End of Life Care and Nurse Coaching. And I would ask you, the way we're going to change things is one nurse at a time. Once our own consciousness changes and the way we view our nursing and the way we care for ourselves or respect that we do need to care for ourselves changes, we will change the consciousness of many. Nurses make up the largest sector of healthcare, okay, in any institution. And I really think that if nurses take on this new model, this new way of being, that we can truly make a difference in ourselves, in our profession, and in those lives that we so humbly and so graciously are afforded the opportunity to care for. So thank you for listening, and I hope I get to meet each and every one of you. I'm looking forward to seeing you, and if you have any questions, I'd be happy to field them. Thank you.
Thanks.
Thanks. Yeah, thanks, Joanne. I left some links in the chat box for everybody. The ones that are mentioned on this last slide, they're both available in the chat box if you want to open that up.
Oh, okay. Let me get to. Do I have to go to the chat
Oh, no,
box?
no. Just,
Oh, okay. Okay.
That's just for everybody listening and watching. Yeah, thank you. It was a terrific presentation, and in many ways, you highlighted different aspects of what we did the previous week in a different way. I especially appreciated your emphasis on the more reflective and contemplative elements. As somebody who's a non-nurse but who's experienced end-of-life care nurses with my grandmother recently, I certainly can attest to the value of that kind of care. It's a completely different way to go through that process as a family member, and just also to kind of appreciate. I guess for me anyway, just to kind of my own little testimonial, it's a different way to experience the dying process in a way that emphasizes the living process and like how to value life and what are you going to do with your years, as you mentioned very succinctly and very memorably, that once you realize there's an end point to this life, you start to really value what you do between the years that you've got left, and you don't know what that is. So I really do appreciate that, and I think it's very important. So thank you, Joanne, for your presentation today.
Yes, you're welcome.
I just going to thank you too from me, and I'm sure from all of us out there. Just I so appreciated everything that Jeremy just said. Same from me too, but your emphasis so much on the collaborative community aspect too, and those two very powerful images at the end of one story and another story, that just kind of really hit home, of the sort of our modern way of living. And I mean, my whole family has been in hospitals, worked in the medical profession, so I grew up spending a lot of time in hospitals, and I always found them very warm places, just because of the way they were, these particular hospitals in England. But just that image of that room, and as you said, some people might choose that, but then the next image of people, a person surrounded by a huge extended family, whoever that is, maybe they're friends, that came through with your whole presentation as well for me. Just this, and on the coaching, the course coaching, that you do this together, this kind of collaborative, not directive approach that you really emphasized across the board, sort of, and this whole thing of nurses taking care of themselves, being keen on each other before they give back. That's a huge shift, I think, which is crucial in all fields, but particularly nursing, as first responders that then stay, which you also emphasized, the first responder element, but staying then with the patient, the client, and not stepping away. You need extra strength.
Yes, we call it resilience in nursing, and the literature, terms it hardiness, but it runs out.
Yeah.
Unless we really learn to be conscious and aware and live our lives fully present, which we tend not to do because the very nature of choosing a role that is a caregiver, a professional caregiver, we're used to giving out. We're not very comfortable with receiving. And some of us don't even feel that we should receive
Yeah.
for whatever reason. And it's important to have the opportunity to dig down deep and to really figure out what it is that perhaps is not making me or someone or a nurse feel that they're worthy of caring for self. It's very important. And, I love what you mentioned just a few minutes ago about the story where I show the two pictures. They're two very different scenarios. And this brings me back to, again, to highlight the importance of the coaching process and self-determination and autonomy, patient autonomy. And, autonomy is a wonderful thing. And to have someone, have self-determination is a wonderful gift in this country, because we live in a pretty free country so our choices can be honored, our health preferences. But how do we get someone to that point? How do we know that if we don't talk to people or have these conversations throughout life, how do we know if that's truly what their choice would be? So I think on so many levels, and, we could talk about this all night for a 2-hour webinar. During the course, we're going to have these deep conversations, and stuff will come up for us, years and years of layering. I often say nurses are like an onion. We have to keep peeling, and when we're peeling, our eyes are tearing, and all this stuff comes up for us, which is so, I don't know, it's so exhilarating in some ways, because, you're with the nurse coaches and you're with your colleagues who get it. We get it. We get what each other's feeling, and it's just a wonderful. It's our way back home to our nursing. That's what it is. Our way back home to one another, to ourselves.
I like what you said too about that approach, that really deep approach when you're sitting at the bedside of somebody that is living with terminal illness, and sort of reaching that, being able to help bring out their deepest wisdom.
Yes.
Where they actually want to go. Like, I really picked up on that, because other people do help that process in you, in any area of life. But I mean, what deeper part of life than when you're dying?
Henrietta, it's so funny you're saying this. Could I share a story? I guess we have some time. I would love to share a story that illustrates this so beautifully. I was an ICU nurse. I was a family support nurse, and a client was in the ICU. And she was a 56-year-old woman who had a pulmonary disease, but she really just couldn't breathe. So the nurses were very upset because she was refusing to be intubated. And that, for you guys, going on mechanical ventilation. Mm-hmm. And so they said, you have to come down and you have to talk her into this. So I said, oh my gosh, I'm not going to talk her into anything. I just need to go and see what's going on. So I sat by the nurse's station and I watched the patient in the bed, and she was having a rough time breathing. She was still very cognizant, and alert. And they bring her dinner, and I see her trying to cut a chicken breast. You can all appreciate this, nurses, with a plastic fork and knife. And I'm saying, this woman can't even breathe. How dare they even put a chicken breast down? So I said, okay, this is my in, So I go up to her and I say, her name was Joan. And I say, Joan, it looks like you're having a hard time here with this chicken breast. And she, looks at me, and I'm not going to, she goes, yes. And she was having trouble breathing. And I said, but I really didn't walk over here because of the chicken breast. I walked over here because I know you made some pretty tough decisions today. And that was it. She opened up her dialogue to me. And she said, yes, I said, how do you feel about those decisions? I mean, do you know what's going to happen, as a result of you not being, placed on the machine to breathe? And she says, yes, I do. And I'm ready to go. And I said, well, tell me what makes you ready. She said, I've been living with this disease for a very long time, she says, and I keep coming back to the hospital. And I know if I get put on this machine, I may not come off this time. And she says, I'm ready. She says, I know many more people on the other side. Like my daughter died 25 years ago, she said to me, from appendicitis. Would you believe that? And she said, I would love to see her again. And my husband died a few years ago, and I miss him terribly. So she said, the only regret I have is that I have a son who has, cognitive issues, and he's disabled. And I feel bad to leave him. He's an adult, she said, but, she said, I have my pastor is going to be his guardian, she said, and I know he'll be okay. So we kept talking, and then I said to her, so she said, I can't wait to see my daughter. And she told me all about her. And her name was Joanne, which is my name, which I couldn't believe. And I said, so who do you think's going to come for you when you cross over? And she goes, I think my daughter will come for me. And she said, I'm going to be so happy. So we were talking like Joan was going on a trip to eternity, so comfortably. And the next day, she was having a real hard time. She was kind of out of it, in and out of it a little bit. And I thought she was going to die that night when I came on the next day, and she didn't. She was up and alert the next day, and her brother was coming from California. And you nurses know what that means, yeah. So she was alert, and I said, Joan, you're still here. And we cracked up, laughing. And she said, yeah. She says, my brother's coming today. I can't wait to see him. So her brother came that night, and Joan died at 5 a.m. the next morning. And she died, that night when her brother came, her pastor came, and the nurses told me that everyone was singing around her bedside the hymns that she loved, and her son came to say goodbye to her. So to me, she taught me so much about my own fear, because I was afraid to approach her. And I was waiting to see how I could approach her. And then that beautiful conversation that we had, like a friendly conversation. It was therapeutic, yes, but there was something very sweet and very sacred about that space she invited me into. So I will never forget her. So I wanted to share that.
Thank you, Joanne. We do have at least one person, Gretchen, who'd like to come on and tell you a little bit about themselves. Gretchen left a message earlier saying that I'm from Portland, Oregon.
Is it Gretchen from Harmony Hill?
Maybe I'm about to add them. Working upstream, doing EOL education with people in the community, already working with individuals and families, counseling about advanced decision making. Okay, awesome, Gretchen. Let me see if I can add your audio. There you are.
Hi, Gretchen. I see that.
Let me unmute you real quick, Gretchen.
God.
Let's see. Try one more time. Hi, Gretchen. There you are. We see you as well.
Hi.
Hi, Gretchen. How are you?
Okay. I am well. Thank you. Wow. I'm right here. Yeah, I have a question. I have been doing this work sort of unofficially. I would say maybe an unofficial coach for the last few years. So I've been talking with community groups, individuals, families, not in the hospitals, not in senior homes, but out in the community. So churches, families, just people that I come in contact with. So I call this upstream work.
Oh yeah.
Where I'm working with people before about end of life decision making before they get to the point where those decisions become relevant and necessary. So it's just kind of a part-time. I call myself an educational service. So I guess what I'm wondering is a lot of the stuff that you had in the slides is stuff that it's kind of like my passion already. It's what I teach to groups, and when I work with my the people that I counsel, I do a lot of the coaching type work where we're trying to help them discern their values. We're trying to help them think about what quality of life means to them. And at what point the quality of life becomes too compromised by the treatment options at the end of life. So a lot of that is kind of work that I do where I'm trying to pull that out of them. So I guess I'm trying to think about whether there would be enough new content in a course like this that would justify flying across the country for days. And you probably can't tell me that, which is the frustrating part.
What part of the country are you from?
Portland, Oregon.
Portland, Oregon. Okay.
Oregon.
So, Oregon. That's my Long Island accent. My Long Island accent.
Yeah.
So a couple of things I want to say. The end of life component of this will, will have depth. Okay. The coaching component of this, I think, would lend itself very nicely to your work, because we coach, use the coaching model in group process. We use it on one-on-one. And you look at yourself as an educator, which is really great. And I love that you're going upstream and into the communities and having those conversations. But I believe the coaching model would lend itself beautifully to what you're doing. You may have the end of life component, down pat. I mean, it depends what else you want to learn about it. I mean, Jan Booth and I have years and years of experience in end-of-life care, and have developed many, many programs. I mean, that's going to be up to you. You may also consider if there's a coaching course out on the West Coast. I know now today in San Diego, they're doing module 1 of nurse coaching. You may, want to take just the nurse coaching component of this. And then waiting for it to come to the West Coast. We just finished the whole module on the West Coast in Washington, in Union, Washington. Now they're doing in San Diego. We won't be doing one there for another year.
Okay.
Also doing another one out in Sag Harbor in May. But it seems that with this course, you're getting like the depth and breadth of everything that you need all at once. I mean, and you get to come to New York City. So, I mean, it's up to you. I mean, but I think the course is well worth taking, especially if you're doing this work, and you can add the coaching piece to the work you do already, because dollars to donuts, if you take the course, you're going to say to your supervisor, wow, I've been doing so much teaching and not enough coaching.
Yeah, I am my own supervisor.
Yes.
I'm pretty much self-employed. This is what I do. I'm independent. So it's kind of my own gig here. It's my own passion. And I kind of am the only one sort of doing this. I think most everybody else who does this kind of work is associated with a particular healthcare system. And I'm kind of out here in the world sort of doing that piece. Yeah. I had
That's going
another
to be up
question.
to you. It's going to be up to you. Do I think it's worth coming across the country for? Yeah, I do. I think it's going to be a fabulous course. We worked very hard on putting this together. It's going to be experiential. You're going to learn about yourself. It's going to attach you to a community of nurse coaches, perhaps since you work alone in Oregon. There are nurse coaches there already.
Mm-hmm.
You may even create a group of nurse coaches. I don't know how involved you are with doctors' offices or with training nurses or anything like this in the coaching, in what you do, but the coaching model will lend itself beautifully to your work.
For those of us who do come from out of town, how does the lodging? I don't really have any idea about where one would stay.
There is a list of different hotels near the area that Inca will provide, or the Open Center might have a list even. So when you register, you'll be given a list of potential places that you can stay.
Okay. All right.
A nice part of Manhattan.
Great.
Can I just jump in, Gretchen, as a
Sure.
Manhattan? Yeah, I live in Manhattan. I mean, another really affordable way a nice way to stay in New York for something like this would be Airbnb, where you can rent rooms from people. I mean, I used to do that at my apartment, but for a period of time, it sort of feels like you can kind of get nested in somebody's home, or and it's a little cheaper sometimes.
Right.
Just putting that out there as a resource. I'm sure you've heard of it.
Yes, and another possibility might be room sharing. If there was a way to let people that we would be interested in that, and you could hook us up maybe with other people who want to room share.
Yes. As a matter of fact, I will email, Ronnie Tanker is our program manager, and I will email him and tell him, what you just said. Yeah.
Okay.
We always room together, nurses. We used to have our coaching sessions and the modules at what we call Alma Matthew House in Manhattan, in the Village. Alma Matthew was a missionary who used to have women come into her brownstone in the turn of the century, the turn of the 20th century. And it was like dormitory style. So many of us shared rooms there, and, it was a bathroom and, so yeah, we're very used to doing this sort of thing. So yes, I can definitely find out. I will, once you go on, I will definitely bring this to their attention.
Okay. All right. Thank you. I appreciate your answers to my questions.
You're very welcome. It's nice to meet you.
If I think of my other question, I'll pop back in.
Okay.
Thanks.
Take good care, Gretchen.
All right. Thank you.
Bye-bye.
Alrighty, so we have one other person who has their hand raised, Emlor. I'm going to try to bump you up to the panelist list in just a second. Let's see, promote to panelist. Here we go. Hi, Emlor. Not sure if you can, we're seeing something. If you can just speak up, let me just unmute you, see if you have. You there, Emlor? Well, maybe not. That's okay. We're going to leave you on the panelist list if you can get your microphone back. We see your video cam on. Maybe they just stepped away, but we saw your hand raised. So if you do want to come back, you can also leave your message in the chat box for us really quick. Thanks. Okay, so I think those are all the questions we have.
Okay.
If anybody else who's on has any questions they'd like to ask, now would be the time. We have just a few more minutes before we hop off. It would be great to squeeze in a live question.
Oh, I see some more hands going up there.
Here we go. Peg.
And Linda, yeah.
Great. Let me just invite Peg. I'll do Linda first, just in order. Okay, Linda, I am adding you to the panelist list. We see you. Perfect. Can you hear us?
Me?
Yes, we do.
Hello?
Hi, yes, we can hear you.
Okay. Hi. I have a question about the independent portion of the program, how that is carried out.
Mhm.
I am actually retired, and I'm a longtime nurse, and I am no longer connected to any kind of a clinical practice. So I'm really interested in this, even if I do volunteer work for myself. So I'm wondering, what is the independent study all about? How do you do it? How do you get connected to patients or whatever?
Okay, sure. Well, it's nice to meet you, Linda. Thank you for your question.
By the way, I just have to say, I know Susan Luck from
You
many
do?
years ago because I was in nursing education. I've been teaching nurses for many years, and
That's
I worked with her
wonderful.
on a wellness program for nurses a long time ago.
Oh, wow. So what's your
Yeah.
last name? I'll tell her.
Ervolino. It's many years ago. She may remember me. And mentioned she knows I know her through Gina Anselmo.
Oh, okay.
You know Gina Anselmo? Okay.
So, okay, I will tell her, but let me explain answer your question. What happens is, again, you do the first module, and then in between we do 6 calls, which are usually a month apart. Not even, I mean, maybe, a few weeks apart. And there is a number of required assignments that you have to do. We usually get patients. You have to do 24 patients, an hour, 3 times each, an hour session each. And you usually record those sessions so that you can listen back to learn. You only have to write 3 of those sessions up. We usually get clients from anywhere. It's all voluntary. You tell them you're learning. They sign Inca will provide you with some contracts, not formal contracts, but so that they know what their role is, you know what your role is, and they'll be willing to come to you for at least 1 intake and then 3 sessions.
Okay.
We get clients. Some of us have gotten them from extended family members, not too close, but so-and-so's sister-in-law who really didn't know the person, or on Facebook asking if anybody would like, that you're a student, if anybody would like to be coached for free for 4 sessions. We get clients that way. Through friends. We don't, if someone wants to get clients in, say, their hospital setting, we discourage that because that may be a conflict of interest if you're working there. So that would have to be done outside of the workplace.
Can I just interject there? So I've worked for many, many years at NYU Langone Medical Center, and I'm no longer working there. I retired.
Right.
And I'm wondering if, because I even know some of the people on the palliative care team there, since I'm not working there now, if they would give me access to patients, would that work or not?
Well, that depends. I don't know if they would give you access to patients.
Yeah, I'm not sure they would either.
And but you could certainly coach the nurses.
Oh, okay. Yeah.
And that's not saying if there were a patient there, if they recommended you,
Okay.
but you would have to come in as a student. You wouldn't,
Yes. Sure.
of course.
Sure.
But none of us have had any difficulty getting patients to.
Okay. Okay.
We find them, and you know what the thing is? After someone comes to you for the first time, the thing is that they feel as though they've been listened to.
Mm-hmm.
And what I realized through this whole thing is most people have never felt as though they were listened to.
Mm-hmm.
And if it's at the very least, they get to tell their story, someone who holds space for them and can listen to them.
Mm-hmm. Yeah.
So we never had any difficulty getting patients.
Okay. Thank you.
Very welcome.
Great, thank you. We're going to try to see if we can add Peg now. All right, so Peg, I don't see a video feed, but let me just try to unmute you. Let us know if you can hear us.
I can hear you. Can you hear me?
Hi, Peg. Great. Yes, we can hear you fine.
Okay. My question is, I'm trying to understand how can I incorporate this course into a new career, but kind of stay in the institution where I work at. And I'm not sure how this all fits in, or are there jobs that would hire a nurse coach with the end of life experience? So I'm just trying to understand how I could fit all of that into a new career.
Okay. Well, thanks for your question, Peg. It's nice to meet you. Yeah, well, I'll give you a couple of examples of what's been happening. We have one nurse coach who is out of Michigan, in a health system up in Michigan that really just merged with other hospitals. And she went to her employee wellness program and told them that she was a nurse coach. And what they've done is she has her own business, which is an LLC corporation, and they hired her business to do all the health and wellness coaching for staff. So they refer patients to her through their staff. So that's one way. I have my own business where I have, and I work out of my house for now, where I see clients, out of my house, and I have my coaching business that way. Others are, there's another health system, Meridian Health in New Jersey. They're just hiring only nurse coaches. So to put in their health and wellness, their oncology. Also, another place where nurse coaches are definitely going to be needed is in the survivorship programs that have to be instituted now. By 2017, they have to be up and running.
Right.
Totally up and running. So nurse coaches are going to definitely have a place there. And also, if you go on Indeed, I don't know if you've subscribed to it, Indeed, which is an employment site for nurses. Right. You will see nurse coaching positions being advertised there as well.
Okay.
So they could be used as, I know some of my colleagues as nurse coaches down in Washington are navigators, nurse navigators, case management. It can be integrated into any aspect of healthcare.
Okay. And that the survivorship, and would that be like end of life? So that,
well, it's survivorship for cancer, with breast cancer.
Right.
Survivors, and now the survivorship programs are going to be implemented. All the hospitals have to have a survivorship program, and there's a different. I'm not sure of the exact percentages, but by 2017, it has to be 100% up and running.
I see.
So that's another avenue. And also, if you look within your own health system and look at this can be implemented even in a disease trajectory, like across the service line. So let's take congestive heart failure and let's take HCAP scores. Okay, all of us nurses know what those HCAP scores are. And say if you have, frequent, hospital ED visits and hospital readmissions and poor medication adherence with patients who have congestive heart failure. There is a place for nurse coaching in the hospital setting and through transitional care and home care. And I really think that the coaching model will really affect hospital readmissions, unnecessary emergency room visits, and will, improve medication adherence. So, some of us, it's, you have to remember this is a new innovation and we're implementing now in various places, and you're going to begin to see some outcome research. And it would be a great opportunity to do some outcome research. If you have a magnet hospital that needs to do nursing research, this would be a perfect model to look at. I mean, you can look at it as a wellness program for nurses. You can look at it through a disease trajectory or across a service line. You could do so many things with it.
Right. Okay. All right.
So there's a lot of possibilities.
All right. Thank you.
You're welcome.
Great. So we have one last question that was squeezed in, and thank you, Peg. Let's see if I can. This is from Gretchen. Let me see if I can bump Gretchen back up to the panelist list. Hi, Gretchen. Not sure if you're still there. Gonna try to unmute you. Okay. So I think it's just taking a while to load, but Gretchen did write her question here. And she writes, another question. Will this course be spending a lot of time clinical beside care at the EOL? Some of us aren't doing that work and don't plan to, so wondering what the balance is in the course. Oh, sorry, a lot of time on clinical bedside care.
Oh, on clinical, okay. Yeah. No, it won't. We will have some curriculum that addresses symptom management and pain management. But this isn't for nurses to be at the bedside with the dying. This is going to be a course that enhances the way our conversations with patients throughout the trajectory of illness. It's more about how do we help clients live well with illness. How do we integrate that the coaching model throughout that trajectory? It's not, what do you do when someone's dying? They're going to breathe like this, we give them this, no, it's not an end of life course that teaches you how to be with the dying at the time of death. It will cover a little bit of that, but that's not the focus. The focus is how do we integrate the coaching model throughout the trajectory of chronic illness. That's going to be the nuts and bolts of this program.
Right. Thank you. And I do think it's important to be able to understand some of the trajectories and some of the likely things that people will experience as they move down their road. So I think that's valuable. But yeah, okay, good. Thank you.
Gretchen, that's where our nursing comes in. That's what makes this so great, because we don't have to learn about the trajectories. We know what it's going to look like.
Yep.
Basically, we have an idea. So we take all of that nursing experience and we marry it to the coaching competency.
Right.
So, we'll cover some, end of life, but it's more about living well.
Sure.
So. Yeah.
Great. Thank you again.
You're welcome.
Great. Thanks, Gretchen. I think that's it for our questions tonight. So unless Henrietta, you had any closing thoughts, we're coming up at the end of our session.
No, I just wanted to thank you, Joanne, really, for a really marvelous presentation, and all of you out there who've participated. It's been great to hear from you, fascinating to listen to the dialogue and conversation, and just what a great course, Joanne. Amazing.
It's really, we're looking so forward to it. It's been a long time coming. I think that this course is going to be an eye-opener for everyone, and it's really going to have utility to every aspect of nursing. I really do.
Yeah, and also just so important in the times that we're living in, where we really need to be coming together at all junctures and, and stay together. So this conversation around, illness that you've pointed out so well, that, we can live well with any circumstance.
Yes.
Together with support.
Yes.
That seems to be the focus of your whole presentation. It's taking us deeper into that process of learning and being together.
Yes, that's very important. I often said to my patients, I can't promise you anything because I don't have a crystal ball, but I can promise you one thing, that I'll be with you no matter what.
That's amazing. Yeah.
That's what nurses do.
And that, God, if I heard that, that would change everything.
Yeah, I know. I'm going to be with you no matter what.
Yeah.
That's what we do as nurses. It's not, we get that privilege.
Yes.
And it's quite astounding, and it's humbling.
Yeah.
But it's amazing. So that's what our profession, that's the gift of nursing.
Yeah. And then taking it into nurse coaching, which is wonderful.
Yes, and taking that right into nurse coaching.
So Jeremy, do you have any closing thoughts? Because just a big thank you from me to all of you out there. It's been a wonderful evening.
Thanks to everyone.
No more thoughts on my part. Just again, thank you, Joanne, for your presentation. It's been very informative, and thank you everyone for your questions, for participating. This has been great.
Thank you, everyone. Have a good night.
Yeah, thanks.
You too, Joanne.
Thank you.
We'll
Bye-bye.
be sending out the recording soon.
Yeah.
Great. Thank you so much. Take care.
Take care. Bye.
Bye.